Can broadband technology reduce your odds of ending up in one of these? Officials at Massachusetts General Hospital say yes. As part of our wall-to-wall coverage of this year's National Conference of State Legislators Conference, NextGenWeb caught up with Doug McClure and Dr. Joseph Kvedar of Mass General's Center for Connected Health, the hospital's telemedicine arm. Mr. McClure is the corporate manager of the center, and Dr. Kvedar, a specialist in dermatology, is the center's director. The center's work with broadband technology has led to better care for patients, and in some cases, lower costs for the hospital. Patients being remotely monitored require 40% fewer nursing visits to the home, and the technology has also led to a 33% reduction in hospital admissions. Better care for patients and real economic cost benefits for the hospital. Do McClure and Kvedar think that more universal broadband deployment could have the same effects in telemedicine programs across the country?
Absolutely. What we're talking about is connecting patients to providers, and the richness of the experience you get when you have a positive visit in your doctor's office has to do with the communication and the richness of that communication. We really can't achieve that without broadband. We can do right now what we do with phone lines and so forth. There's a lot of workarounds to achieving that vision, but we really can't achieve that without high bandwidth.
Okay. Can you talk a little bit about the economic side of this with regards to when you're researching potential technology that can be used to provide care? That obviously takes money to invest, perhaps, in that technology. Can you talk about the process when that technology becomes a sustainable program? And do you often see a recouping of that investment once that new technology takes full effect?
Sure. And I think Doug will have a lot to add here as well, because he spends a lot of time thinking about this issue. What I would say is that healthcare has, we all know this, a lot of expense in it that is unnecessary expense. And one of the places where that expense is concentrated is in the inpatient environment, in the emergency room. So many of our programs are designed to care for patients outside of those environments, better care for them in their home or their workplace, keep them from getting so sick, so acutely that they need to come to the inpatient environment or the emergency room. And that's where we see value unlocked when we have that kind of a return on the investment. So when we look at technologies, we certainly look at usability. It's key. And for our patients, that usability range is broad, from children to seniors. But we also look at the price point of, can we get something to the price point where we can fit it into a fairly narrow margin when we're done. And that, as I said, Doug has thought a lot about that. What comments you have?
Yeah. There's an interesting struggle for all these projects and programs, because what we're trying to do is we're trying to innovate, and when we're innovating, we're doing things in an expensive fashion, right? When we run research, we spend a lot more per patient than we could ever afford to when we're going to run the program. And we do that, in an educated fashion. We're placing bets that the cost of technology is going to drop over time, and history bears that out, so we're in pretty safe territory there. What is the great unknown to us is kind of process innovation, and how much we're really going to be able to save in that, and how you're going to be able to redeploy those care delivery kind of resources, people, and redeploy the administrative side of the care delivery. So the other part of it is when we think about an ROI, we really have to attack it from two different standpoints, right? There's a cost effectiveness piece. Can we make the whole delivery process more cost effective, take some cost out? But in the end, there is value that's driven back into the care process. So the healthcare system can do a lot of this experimentation, but over the long haul, new reimbursement schemes have got to be figured out to help us. Otherwise, we're just never going to get the kind of adoption that we're looking for.
Sure. Well, in these discussions, the question of government always comes up, and government can either, be a help or a hindrance.
Yeah.
In your opinion, what can government do? I mean, you all are doing great work here at Mass General and your telemedicine program. What can government do to not only ensure that your program continues to be successful and grows, but to make sure that nationwide programs like this can be established and flourish?
I think the number one thing that government can do is to really embrace quality-based reimbursement policies. If you ask over and over again at conferences we go to and discussions we have with a variety of folks, what's holding this business up? Is it the technology? Is it the 9 times out of 10 people will say the reimbursement environment simply is wrong for what we need going forward, not just from a telemedicine perspective, but from healthcare at large. So whether it's pay for performance or other ways of reimbursing for quality, that's really where we need to head. And the more boldly we can do that, the more that will drive interest in the kinds of technologies that we're promoting here, because they offer us, again, a population view, a population-based management system, a way of promoting patient self-care that's very patient empowering and yet lowering cost. And they also, as I said earlier, keep healthcare it's a less chaotic, less acute event so that people can be healthier without coming into the high-cost part of the system.
Okay.
So really, that's what I would say. I don't know what your comment.
Yeah, it's interesting because the natural struggle has been between the payers and the provider community, whether that payer be the private.
You gave some really good examples on Saturday of your conversations with BC, as you call it, or
Blue Cross Blue Shield, or
Boston College.
Yeah, exactly. And the struggles are, I think those payers are pretty tired on their side of just hearing about healthcare, saying, give me another CPT code to bill against. Here's a new procedure. Let me just let me bill against it. That's not really. I think that's an important and interesting fact about what we're up to in the connected health space. Is sure, new codes to bill against would help drive utilization, but the much more interesting question, and the one that has the larger value for us, is this long-standing kind of quality question, right? If the payer community is open to really engaging in payment for quality, then these programs will be given kind of a fair shot at trying to prove themselves. And some of them are not going to turn out the way we want them to be, right? And that's okay. That's kind of the activity of the research side of our spectrum, and that's how we measure about whether or not it makes it over into program development. Because if they're delivering the quality, then they're going to line up in terms of reimbursement, in terms of where the right value accrues in the spectrum. Does it, are the payers getting the value out of this by not having to pay for more emergency room visits or more hospital admissions? Or are we going to get more value by, again, better bed management or something in our hospital? The truth is both. Just have to figure out how to spread that value out properly.
Right, and that's a good question in and of itself. I mean, for both sides, the provider and the payer, I mean, are there cost benefits to realize on both sides of the equation? Because if you have less hospital visits, I mean, that's less cost for you all to provide care and to maintain, 40 full beds instead of 20, and then of course it's less to pay out on the payee side. Is that a fair potential assessment, or is that naive to think that both sides could benefit?
Yeah. Both sides can benefit. The real benefit from the provider perspective is that we have so many patients waiting to get in the hospital that keeping someone out of a bed, if we can, just enables more access for people who need it. So we wouldn't advocate as a hospital having half of our beds empty. That wouldn't make sense. But we don't need to worry about that because the demand is so high for services. The other driving force that motivates us, I mentioned the cost, and I should say the other half of the capacity issue, if we talk about provider shortages as one half, the other half is the enormous growth in chronic illness. And one of the illnesses we talk a lot about is congestive heart failure, which has increased 500% in incidence in the past 30 years. It continues to grow at a logarithmic rate. So we aren't going to run out of people that need the hospital anytime soon. What we have now is our emergency rooms are frequently not taking patients because we don't have beds, or sometimes when they take patients, the patients end up waiting for 8, 10, 12 hours in the emergency room before they get admitted, and that's not ideal either.